Sounds like you're really enjoying this. Okay. Jay? Okay. All right, guys, let's get started. Okay, and the last thing was to secure the tube, right? And after that is you're going to reconfirm tube placement. Now, this is extremely important. Right now, you want to reconfirm and make sure you've got tube placement. When else should you check that? Do what? Anytime you move the patient, you have to recheck that. Consider, say, that your balloon in there got a little hole in it and it's collapsed. If that happens, the slightest little movement can displace your tube. So anytime you move them, there's one other time where you absolutely have to check it. Anybody have any ideas? Okay, if that tube is dislodged, who do they want to blame for it? You. So you want to check before you leave the ambulance, but once you move that patient over in the ER to their bed, you auscultate and you ask the nurse there, will you auscultate this? And then you document, rechecked, auscultated after moving the patient to the ER stretcher, confirmed by blank, and put their name on there. That is the CYA tip of the day. And it's a good one. Okay, continuously recheck that tube. Anytime they're moved, you want to re-auscultate. That's just what you do. Now, say you auscultate and we're not getting breath sounds. We have a problem, right? All right, I put this mnemonic up here because I'm pretty sure you won't see it in your book. If your tube, if you're not getting air movement, these are the things you're going to think about to see if you can problem solve what's wrong with your tube. So what do you think the D stands for? Displacement. Yeah, who said that? Was it in your book? You're just smart, huh? Yeah, you want to check to see if your tube has been displaced. Has it come out and it's in the gut? How can you check that? Well, if they're just laying there and you're just listening, you got to put breath in there and auscultate over the epigastrium while you're giving them a breath. So that's displaced. What does O stand for? Obstruction, yeah. They may have gotten a loogie on the end of that tube and it won't clear. Is that gross? Good. All right, what is the P? What does the P stand for? You would think that, but that's not it. What do you think the P is? If you overinflate your patient, give it the two-hand squeeze. What does it stand for? Pneumothorax. That's right. So you want to check to see if you've got a pneumothorax. Maybe that's your problem here. Your sats start dropping. All right, what does the E stand for? Haven't heard it yet. Nope. That starts with an A. Anything else? Okay, E is equipment. So you can have equipment failure. Could be your oxygen tank has run dry. Your BBM has developed a hole, and every time you squeeze it, the air goes out somewhere else. So anyway, kind of go down this mnemonic, and it may help you problem solve why your patient's O2 stats dropping or whatever. Okay? That's a problem. Oh, if you're having a problem with your ventilating your patient, either the O2 sats dropping or your capnographer, you're getting crazy, strange things there, crazy waveforms, then you want to check your dope. Always check your dope. This is not Colorado. We're not checking dope in here, okay? All right. Oh, we just recorded that. Thanks, guys. All right. We have a few other ways that you can intubate a patient, other pieces of equipment. We may or may not have some of these, and some of these they'll be favored in one area, Jake, or in another area not so much. So there's a lot of different things on the market now, and every day they're bringing out new stuff. This is a lighted stylet, and what happens here is the tube is actually over that, and you pull the little light thing out. It's almost like a stylet. It's got a light on the end, and you pull that out, but you can see that light is not in there to light it up inside like this little bulb. How are you going to see it? Yeah, you can see it on the outside of their skin, particularly when it's darker. You can't see when it's real light. But you can see that light pass through. If you're passing that in the esophagus, you're going to see the light? No. You'll see it because it's just right up here, just below the skin pretty much. Insertion of that, we're not going to go through that. If you actually are using this device, you should be trained on it. If you go to a service that uses something that we haven't practiced on, you absolutely must insist that they go through it with you. They're legally required to go through it with you. But sometimes they're lazy. I know you can't imagine that. And they may just toss you out there. I can imagine that. But make sure you're trained on all that equipment. Lighted stylet. Now here, they're doing it digitally. And that's not necessary. We will go through that later. You can use a laryngoscope with this. But you don't need to. If you can see that light, you know where you're at, right? But yeah, he's doing digital. We'll look at that in a minute. Translumination, that's where you can see that light as it's being passed down the trachea. There's something called fiber optic intubation now, where it actually comes with a little screen. And as you insert your device, whatever you're using, you have a little screen, and it shows you in big color what's going on inside. So you're intubating here and you're looking at your screen there. Personally, I'm going to feel better seeing those cords myself, but these are available. Is anybody around here using them? Somebody's moving to it, yeah. So make sure you're trained on that device. They can be real handy, but they also make you lazy. If you go somewhere and you don't have access to this, and that's the only way you've intubated, and you have to do it the old-fashioned way, it's going to be a problem for you. So, but it is available in some areas, so you can use it. You can see the glottis, the epiglottis. As I said again, just make sure that you're trained on that device and you meet all their requirements. This is a picture of the glide scope. You can see the screen here, and you will be able to visualize that as you're intubating. It's kind of cool. Okay. Blind oral tracheal intubation by digital method. Now this is a real old-fashioned way. If you don't have a bulb for this, or somebody has lost all your blades and you can't intubate, or sometimes you would use this if your patient is in a strange position that it's difficult to access where they are. If they're sitting up in a car, it may be hard to move around there. They may be in a difficult position. I had a patient one time, if you guys were in my EMT class, you'll remember this, who had fallen off of his, what do you call that little chair that you ride around on? The hover-round, yeah. He fell off his hover-round on a Friday, and when he fell, his head fell between a chest of drawers and the wall. And there was only enough room in there really for his head. And he hit his head on the chest as he went down. So he was unconscious for probably a large part of that time. But he bled, and all that blood went down in that, I'm dating myself now, shag carpet. And so when we went there, we could not get him out of that spot to do anything with him because his head was basically glued to the shag carpet, which is between the chest of drawers and the wall. The only way we were able to intubate him was this way. We couldn't get behind him, couldn't get to the side of him. All we could do was this way and drop the tube, and it worked great.
How long were you on there?
They found him. Somebody found him Monday morning, so we've been there from Friday sometime to Monday morning. Hungry was like half dead. He was sick anyway. It was sad. But anyway, so this is a digital intubation. So you're not going to use a laryngoscope. You're not going to use a handle. But everything else is going to be the same. You notice that he does have his gloves on. Any patient that you're going to digitally intubate, what must be their mental status? They must be profoundly unconscious. Like this guy, I mean, he was so unconscious, we kicked him several times by accident. And just trying to get to him. But he was profoundly unconscious, so we were able to do this. Because if they're not completely unconscious, is there a danger with putting your hands in patient mouth? Yeah, bad. Okay, so the way this is done, wait. I've gotten my slides mixed up, so I'm going to tell you, but we'll find it here in a minute. With a digital intubation, Remember the anatomy of the airway, because y'all all pass that on your test, right? Wasn't that on your test today? Remember I told you that on the front's the trachea, right, and the back's the esophagus. The trachea, the glottic opening, all that's very small, whereas the esophagus opening is very large. Now, what is the one key thing that's a landmark that's really special to the glottic opening that the esophagus isn't going to have? The epiglottis. And we've seen it. We know what it looks like. So what's happening here is he's walking his right hand, he's walking his fingers down. I do my left hand. Walk the fingers down this way, and you're keeping it very tight, you know, on the tongue, and keeping it to the superior side of that. And you'll walk your fingers right down, and you'll feel the epiglottis. You can feel that with your finger. So take your long finger and grab the epiglottis and lift it up. So we're basically using what kind of blade here? We're lifting up the epiglottis. It's going to be the Miller. So we're using your finger like a Miller blade. You're going to lift that up. Now I've also got this finger out, right? So what we're doing here, too, without a stylet, that's fine. You're inserting this after you've got the epiglottis. I'm holding the epiglottis right here. I'm inserting this, and I can feel, of course it's not going to be inflated. Let me deflate that real quick. Okay. So I'm holding the epiglottis, and I've got my, is that your index finger? Is that your pointer finger? What do you call it? Anyway, you're putting this in. You're going to slide it just under. You're going to hook your pointer finger, and since I'm holding the epiglottis here, it's only got one place to go, right? Where? It's going to go through the glottic opening. That's right. So it's easy as pie. So you slide, you'll feel that balloon, and just slide it a little bit further, and then pull your hands out, blow it up, secure it, you know, well, check that you're in the right spot. Yes?
So when there's like a voice box taken out, they talk a little bit like that kind of like a little tongue or something.
Do they just like?
No, like a, there's a fellow that comes and work all the time with orders. Well, you can't talk. He talks, it's just like
Probably what happened to him is he went down, he done fell out, somebody tried to intubate him, and they lacerated his vocal cords. I'm just guessing. Yeah, if he's had his voice box removed, he's not going to be making any sound.
You have to make any actual, like no noises like that. It's just with like, it sounds like spit and spit is coming.
I don't know. You might ask him about that.
You couldn't carry on a conversation when you have to take his order.
He couldn't tell you what was going on. Anyway, so this is a digital intubation. There's nothing wrong with doing this. My very first field intubation was a digital intubation because of the way the patient was laying. We couldn't get to him. So that was kind of fun. But they must be profoundly unconscious. There's nothing wrong with doing it. You need to try it at least once when you're out there because it is kind of fun. It's very fast. You know, you're not worrying about looking, do you see the vocal cords or any of that. You just walk your fingers down, you feel the epiglottis, and you just slide that tube in. Okay, did I miss something else? No. Okay, when you've got your laryngoscope, you want to, this doesn't really go with this. This is describing this bougie, which is this little thing right here, and we've got, it's very flexible. We've got some in the labs. We'll look at those next week. Now here it shows you placing the bougie while you're looking, and this is much easier to place in a tube because it's very small. So with your laryngoscope, you see the vocal cords, you slide that bougie down there, then you come back with your tube and you slide it right over the bougie, and then you pull the bougie out. So they're quite handy. There's something else called a salt airway, and I don't think I have that in here, but a salt airway is a kind of a plastic knobby thing, and you place that in the patient's throat, and it has a little opening that is tilted up, and you just never mess with that thing. It always goes into the trachea, so it's super. Okay, see, I need to move those slides around. This is the digital intubation. If you can see, your long finger is reaching for, it's an odd picture. I don't know what it's doing. It's not my picture. Here you can see they're going to lift the epiglottis so that you can slide that tube through here. I don't like that picture either. But when you walk your fingers down, you'll palpate the epiglottis. Even with your gloves on, you'll know. You can feel it. and just lift it up. Then you insert the tube right next to that finger. It's pretty easy. I know this is gross, but I mean, I hate these little side views. But here you can see the epiglottis, and you can see the finger coming in. That's a small epiglottis. To lift that up, and you slide that tube right through there. Yeah. It's pretty nasty, isn't it? Pretty gross. Anyway. Pretty nasty. Somebody donated their body to science. Okay. Moving right along. Sometimes you might have to intubate a patient with a potential spinal injury, so you're holding C-spine with them. You can go ahead and put a C-collar on, and I recommend that before you try to intubate them. That's going to help you remember, and your partner, whoever's helping you, to try to hold that inline stabilization. If you're not able to intubate, or you're not able to get an airway, you're not able to bag a patient who has a spinal injury because you've got the C-collar on, in that case, which is more important, spinal mobilization or patent airway? It's going to be the airway every time. So if you're unable to get an open airway so you can bag your patient or intubate them, then you may have to release that C-collar and tip that head back just enough so you can get the job done. It doesn't mean ratchet it all the way back, but just enough so you can get an airway there. When you're trying to do this, you need to make sure that someone is securing spinal mobilization there. Somebody's holding that. Whether you got the C-collar on or not, you want somebody to secure that. Then you want to make sure you pre-oxygenate the patient while they're doing that. So if you can't ventilate them while they're holding C-spine, you may have to tip the head back a little bit. You do not want air where? In the stomach. So when you're ventilating them, pre-oxygenating before you intubate, make sure you're not filling the stomach, because I hate vomit. You like it, fill the stomach. Okay, Selleck's maneuver may be of some help here with the spinal injury. The Selleck's maneuver, cricoid pressure, may bring those vocal cords up so that you can see them. So I would recommend that, or actually bring them down on that. Okay, make sure you ventilate the patient after you insert your tube. Auscultate well. Okay. From the time you place that tube, you need to hold on to that tube until you've got it secured. I can't tell you the number of times I've seen people, they set the tube and then they go off scrambling around for all of their stuff. No, you don't leave a tube naked there unsecured. It's either got to have your hand on it or it's got to be secured. There's no other opportunity for you. So before you do your intubation, make sure you've got your securing materials right there. And actually it helps to have somebody there to help you put that, particularly this little gadget, get somebody to help you with that. But you need to note where at the teeth line that tube is. If you look at these tubes, we'll look at them in the labs, they got numbers all along here. They're little centimeters. Usually around 22 is where it's going to be at the teeth, usually, and it will depend on the size of the patient, how long their neck is. People with a long neck, it's going to go a little bit deeper. Short-necked people, it's going to be shorter. Short-necked people, I just recorded that, sorry. Short-necked people, it's going to be shorter. So you need to note that. As soon as you finish your intubation, you've auscultated, you know you're in the right place, you might even take a magic marker or a pen and make that mark. That's the mark at the teeth. If you look down there and that's moved, you've dislodged your tube. It happens very frequently. So I like to put a mark right there, because my brain won't remember. It was 22, 22 and a half, whatever it was. So I'm usually going to mark it and then secure it. So if I see you in the lab letting go of that tube before it's secured, I'm going to bring, my wooden spoon that I spank my kids with, and I'm going to snap your hands with it. Will that help you remember not to let go of your tube? Yeah, it's going to hurt too. You better hold on to it hard, I can tell you. Okay, secure the ET. If you hadn't put the cervical collar on, or if you're taking it off for your intubation, make sure you put that back on. and then reconfirm placement. Even after you've checked it, now you're going back and putting the C-collar on. You want to recheck it because you've manipulated the head somewhat. You shouldn't, but it's a good chance that you have. So always reconfirm. Okay, intubation complications. Have we already done this? I thought we had. Accidental intubation of the esophagus. That's always bad. I think we did these, didn't we? No, we didn't talk about laceration of the lips or the tongue. Don't lacerate those things. Now, from time to time, you may have a patient with a bleeding disorder or somebody possibly with an esophageal varices. Y'all know what that is? Is it the grossest thing you've ever seen? It's the grossest thing I've ever seen. It's where all you have to do is touch the side of their, inside of their mouth, really, or their throat with the end of that tube, and you've unleashed, gallons of blood. So you need to be very careful with this and try to keep it off of the soft tissue. Talked about that. Yeah, I talked about that. Yeah, if you're really rough with this and you're not careful, you can lacerate their trachea. That's never good. Because then what happens? Air goes into the thorax, yeah. And what do we call that? Pneumothorax. How about that? And of course you can injure their vocal cords. Sometimes you'll talk to patients that come out of surgery and they've got a scratchy voice. Their throat may hurt. Sometimes they have a permanent injury from that. So we want to be as gentle as possible. And of course, aspiration is never good. Possible complications. Now, also, when you start stimulating the back of the throat, when we stimulate the back of the throat on a child, what happens? It stimulates a vagal response, which will cause what to happen?
Bradycardia.
Yep, they become bradycardic. And little kids, if they're already compromised, and you start stimulating their parasympathetic nervous system, they may brady down and then lose their rhythm altogether. But by stimulating that area, sometimes it can cause a release of catecholamines, epinephrine, tachycardia. It can increase their blood pressure, and frequently you will see cardiac rhythm disturbances. So be real careful and try to keep that tube off of anywhere the back of the throat. It doesn't touch anything except those vocal cords when you're going through. So that whole jam it till you get it doesn't cut it. Vagal stimulation, I just mentioned that. It's not good for kids. It can cause an increase in intracranial pressure if you've got a patient with a head injury. Now, patients with a severe head injury, we like to intubate them early because that pressure on the brain can cause trismus. It's not Christmas. Trismus, what is that? Clenching of the teeth. So if they clench their teeth down, it's going to be very difficult to intubate them. How will you be able to intubate them if they've got clenched teeth? Could you do a nasal on a patient with a head injury? Probably wouldn't do it there. So that's why they're introducing paralytics. So not next week, but the following week, we're going to have somebody come in and talk to you about using paralytics.
And then we get to try them on each other?
I'm going to try it on whoever I choose first.
Okay.
You want to be on the top of my list?
Just dose it real low so it doesn't completely knock me out.
I want you to remember it,
Yeah,
believe
that's what
me.
I'm saying. I remember that. So.
With paralytics, hopefully the guy will emphasize this, but when you paralyze a patient, if it's at all possible, you want to pre-medicate them with some type of a sedative. Can you think of anything worse in your life than to be wide awake, severe respiratory distress, or respiratory arrest, and all of a sudden you're paralyzed? Is that not a nightmare? That's something that can give you bad dreams. So if at all possible, you want to pre-medicate those patients. I worked with a guy that paralyzed a patient 4 times in one day. 4 times in one day. The likelihood of that being needed is like nil. But anyway, the poor guy just died of the flu. That paramedic down in Florida, did y'all read about him? Yeah, he was up in Northwest Florida. He and his wife both got the flu. She's hospitalized at UAB, and he died from it. That's real scary. But anyway, have y'all all had your flu shot, right? I don't want to catch any flu in here. Did she get her flu shot? She still got the flu? Maybe it's not bad flu. Okay, so when you go to intubate a patient with a head injury, you got to recognize that you may increase their intracranial pressure. It's not good. Other problems, if you have equipment problems, you know, the balloon malfunctions or something. So RSI, I thought I took this out. Rapid sequence intubation. We're going to talk about that in a couple of days. I'm going to have to, yeah. See, I didn't realize, I was working on this yesterday, and he didn't tell me till last night he's got somebody coming in doing this. So I'm going to talk briefly about the pediatric airway. I may get done sooner than I thought. The pediatric airway is, their trachea is very flexible, as well as being narrow. It's narrow, of course, because they're children. But it's very flexible. Their tongue is very large. So that makes it more challenging for us when we're trying to do an intubation. You know, you lift that up, and it's a small space anyway, and now you've got this big old tongue, right? It's going to be hard to see around. The epiglottis is floppy, and it's kind of round-like, so it's difficult to control. Now, another issue that you'll notice, and you'll only notice this when you're doing a live intubation on a child, the airway is much more superior, anterior, or you may call that higher. It's hard to describe it, but when you when you look down the throat of a adult patient, those structures are lower. When you look down the throat of a pediatric patient, they are very high. So you've got to work. You almost have to come at this angle to get down. Whereas for an adult, it's a straight angle. So the kids, it's going to be very anterior, so it's going to make it much more challenging for you from that standpoint. You know, they don't have the length of neck yet, so it curls up almost. The angle is bad. The vocal cords slant upward, so they're harder to see because of their orientation. And they're much closer to the base of the tongue. Then with the adult, you've got a wide space from the base of the tongue to where the vocal cords start. So there's, you know, maybe a space of, you know, an inch or inch and a half that you're gliding through space with your tube. With a child, not so. You see the base of the tongue, there's a vocal cord. So in that standpoint, it's a little bit easier. Now the narrowest part, you need to know this, the narrowest part of a pediatric airway is going to be the cricoid cartilage. For those of you that have been in my class before, you've seen this drawing before. Let's see. Okay, whose airway is this? This is the adult airway? Okay, whose is this? Okay, let's take a vote. Who thinks this is a pediatric airway? The top one. Pediatric airway, raise your hands. Don't be scared. I hadn't eaten anybody in a long time. It's about half past. Okay, so the rest of you think this is the adult airway? Who thinks this is the adult airway? You're kidding me. Half of you don't have arms. So nobody thinks this is the adult airway? Okay, let me refer you to this. The narrowest part of the airway for a child is a cricoid. So if you look at this, okay, let's try again. This airway belongs to whom?
Child.
Does that look like the cricoid cartilage?
It really does not.
All right, look. This is because you want me to draw some more. Here, let me see if I can help you out. There's my little epiglottis. How's that?
It's a trash can.
Bird nerdy. Who's the guy that lives in the trash can? Okay, one last time. Who thinks this is the adult airway? Raise your hand. Who thinks this is a pediatric airway? You didn't raise your hand.
Who thinks it's a toilet?
I told a fellow faculty member a few minutes ago that I thought I was teaching first grade. I feel like it right now. Okay, this is the narrowest part of this airway. This is the cricoid cartilage. So this is a pediatric airway. This is why they choke more commonly, because crap gets past the top and lodges down here. With the adult, not so. We don't choke on stuff unless we're like really stupid, but we don't choke on stuff because it can't get past the glottic opening, okay? So the narrowest part The pediatric airway is a cricoid cartilage. Did you get all that? Okay. Ventilation of a pediatric patient. Y'all ready? It's harder to get a good mask seal because they don't have the surface area. So you've got to work harder to get a good mask seal on a pediatric patient. Here we're not talking about intubation so much. Make sure you use the appropriate size bag on your patient. If you've got a small woman that looks like she's about 5'8", 4'8", that's not so small. You want to make sure you use a smaller bag because if the larger the bag is, the greater chance that you're going to overinflate them. Make sure you know what your ventilation rate is. It changes once they're intubated. It changes if you're doing just respiratory arrest, and it's different if you're ventilating during a cardiac arrest. So make sure you know those. Those of you that have had me, you know you had to buy that CPR manual. Brush up on that thing because all that stuff is in there, and you will be responsible for that information. Make sure that you see good chest rise and fall with a pediatric patient. How much air do you put into the lungs of a pediatric patient? Enough to make the chest rise and no more. As soon as you see it move, you're done because it's so easy to hyperinflate or overinflate. Okay. Now, when you're trying to determine what size ET tube to use on a pediatric patient, this is the formula. Now, sometimes you'll read, it'll say, just a rough estimate, the size of their baby finger. It's their baby finger, not your baby finger. Or sometimes they may say the size of their larger nostril. However, this is easier. You take their age in years plus 16 and divide it by 4. So if your patient is 2, make it easy. Well, no, that's not easy. 4, okay. Your patient is 4 plus 16 is what? 20 divided by 5? 4. Good job.
Wait,
That's
no.
not
That's 4.
See, y'all tricked me. That's what I get. Huh? No, I was listening to you guys. What a mistake.
We said 4, and we said 5, and you wrote it down.
Oh, my gosh. 5. I saw 4, and I went, 4's not right. Yeah, so you can do that. And you're going to get, halves, that kind of stuff. Now, that doesn't mean it's always a 5. It could be a 5.5. It could be a 4.5. So there's a range there. And it's just their age. I have a 2-year-old grandson that I swear weighs 75 pounds. I mean, he's huge.
I want to see that.
He's huge. He's breastfed for a year. Okay, y'all make sure you know that too. This is just I don't know if this is in your book. Something like this is probably in your books. What do you see in common over here for blade size?
They're all
Straight. Yeah. Now there was one thing I didn't mention to you about intubating a pediatric patient. You're not going to use a cuff. So you're going to use an uncuffed tube. That means this little balloon won't be on there. The reason being, if I'm doing this, remember this is not which patient? Adult patient. I put this through the narrowest part and I'm going to blow this up. Of course this should go straight. I'm going to blow this up to hold it in place. If I put this through the wide part down to here, I don't need this balloon because this is going to be tight around there. So you don't need that balloon in a pediatric patient until they're probably about, 7 or 8.
So say you don't have an uncuffed tube, can you use a cuffed tube and just
Not inflated. Yeah. Good move. Let's put that thing. All right. Into, boy, that was quick. Somebody fooled with my slides. I'm telling you. I should be able to follow that order. Forget that one. Okay, let's talk about nasal intubations. We've talked about digital intubations. Let's talk about nasal intubations. Now, if you think about the way the airway is formed and the action that it takes, what happens to the epiglottis when you breathe? It what? Yeah, the flap comes open when you're breathing. So most of the time, what's it doing?
Going up and down.
Most of the time, it's open because we keep breathing. Imagine that. We keep breathing so the epiglottis usually stays open. When's it going to flap close? When you're swallowing or when you're probably dead, it's going to flap close. Yeah. So, with a nasal intubation, we can't see. We're not using a laryngoscope. We don't have any way to visualize the vocal cords. So, we have to be sure the epiglottis is in what position? It's got to be open. How do we know that it's open? How can we be sure it's going to be open? We can't visualize it. We're doing nasal. If they're breathing, yeah. So to do a nasal intubation, the patient must be breathing spontaneously. It doesn't mean they have to be breathing 20 times a minute. They just got to be breathing. So we will use a nasal intubation in the presence of a possible spinal injury. You know, if you're not able to see the vocal cords or whatever, it makes it more difficult if you're trying to hold spinal mobilization, you can do a nasal intubation. If the teeth are clenched, for whatever reason, you may consider a nasal intubation. The reason that we say you should probably avoid a nasal if you've got a head injury patient is you're worried about a basal skull fracture. If you've got a basilar skull fracture, then they worry that we may put that in the brain. I've never seen an x-ray where any paramedic has put that in the brain. Nobody's ever seen one, but it's just this hypothesis that that could happen. So probably not even going to. If their teeth are clenched, what does that mean? Yeah, they probably got a brain injury. They got some swelling in the brain.
So
if you have, I'm sorry.
It's useful in that situation with clenched teeth, but the clenched teeth is also a sign of a head injury where it's not.
Yeah, yeah. So if their teeth are clenched, I'm going to be real careful about considering intubation there. Of course, if they're fixing to die, like I said, the chance of you putting it in their brain is like slim and none, but it's out there. It's something they can sue us for. If you've got some serious facial injuries, you know, if the jaw's broken, you know, oral injuries and stuff, it may make it difficult for you to use a laryngoscope and intubate. So you may consider a nasal intubation, but they got to be breathing, right? Yeah. So this will never be done on dead people. Okay. Now, why is obesity up here? Their head's too heavy. Yeah, when you've got somebody that is obese, oftentimes they have a lot of excess tissue in this area, both internally as well as externally, and it makes it very difficult to see. Oftentimes, it's like they have a really short neck, and you're not able to see well at all. So with an obese patient, you may consider doing a nasal intubation. Arthritis, yeah, if you can't put them in the sniffing position, if you can't get their head back, sometimes that makes it a lot more difficult to intubate, but it would be the same way if, you know, they had a spinal injury. Okay, so advantages of nasal intubation. You can do it when the patient's neck is in a neutral position. You know, normally we like to hyperextend the neck. It makes the view a little bit better, brings the axis together so we can see better. So if you're not able to do that, nasal intubation is easier. When you do it, it's just like when you put a NPA down the nose, you don't have near the gag reflex that you're going to get if you put an OPA in, right? Same thing with the intubation. If your patient is breathing but they're not solidly unconscious, you know, you try to go in through the mouth and they have a gag reflex. So with the nasal intubation, you have a less likely chance of a gag reflex. And then if they wake up, you know, it's not as bad as if you've got one in the nose as if you've got it blocking your airway, or so they think. It's very easy to secure a nasal tube, very easy. And of course the patient can't bite it. That's kind of weird. Disadvantages, it can be difficult to do, and it does require some practice to get this thing right. It's the kind of thing that's going to make you nervous because you can't see the vocal cords, and you know, if you screw it up, you know, you're going to kill your patient. One thing about this is you do it while the patient's breathing, so you're not going to interfere with their breathing, you know, until you put that down the trachea, then you're going to start ventilating. Otherwise, you're not really interfering with their breathing like you would in an oral. That freaks them out. I have here that's potentially more traumatic for a patient. What are the problems that the patient may encounter because of a nasal intubation? Think about where that tube is going. Infection, yeah. If you're passing that through the nose, you greatly increase the chances that the patient's going to get an infection from that. Or what's the other problem with it? One particular problem? Besides that? Do what? That wouldn't be good. If you deviate your septum, that would be bad. Yeah, if you do some soft tissue damage there, the tissue in the nose is very delicate, and it also bleeds very easily, right? Yeah, seems to. So yeah, if you're trying to poke that thing up and around, you increase the risk that you're going to do some soft tissue damage. So there are some issues there. It may kink. You know, as you're trying to, you know how the nose is shaped. You go up the nose and it goes down like this, and then you got to get it into the trachea, right? So you've got a really sharp curve going there in order to hit the trachea. So you run a greater risk of compromising that. We said infection. Improper placement is more likely when performing blind nasotracheal intubation. You can nasally intubate while you're using your laryngoscope and your McGill forceps. You may be able to guide that into the nose. Why you would do all that? In that case, I'm just going to orally intubate. But they do say that. Blind nasal intubation requires the patient be breathing. I don't know how many times I say that in class and people miss it on the test. They have to be breathing. I'm sorry?
Their nose is not that really bad.
Then I'm not doing it. You have to do it the old-fashioned way.
You wouldn't be able to get in there, would you?
Probably not if it's real swollen now. I mean, you'd be going like this, and pretty soon what's happening? Yeah. So it's not always possible. Now, when you actually perform the skill, now he looks like he's looking down that tube, doesn't he? Yeah, you can't see anything down that tube. What he's really doing, they should be doing, is listening to the tube. Because your patient's breathing, right? Yeah. So when he takes a breath, you know that epiglottis is up. So you just slide that thing in. You're listening. They have devices. There's a device called a band that you put on the end of your tube, and it kind of whistles, you know, and you can hear the patient breathing. And as soon as you pass that through the vocal cords, that whistling will stop. So that way you know that you're in the right place. If you put that in the esophagus, you know, then that airflow is still going to be there. So you want to listen for that, and you should be able to hear it. As you're getting closer and closer and closer to the glottic opening, that sound gets much stronger, so it guides you. And as I showed you early on, if you've got the ring tube, where did I put that thing? That's it. When you've got the ring tube, yeah. Remember I told you if you think you're going to do a nasal, I mean, I've worked with partners that keep one rolled up in their pocket all the time. Is that nasty? Yeah, probably. You know, you roll this up because you're going to, it goes like this from the start of the nose, up like this, all the way around and into the trachea. It's almost a full circle. So wrap this up, put it in your pocket, and then it's nice and warm and flexible, and it'll go much easier. Okay, alternative airways. What do we got here? Oh, yeah. The ETC, that's going to be the combi tube. The esophageal tracheal combi tube. I think that's what that means. And you can see here, now y'all did the combi tube in advance, right? So you should be familiar with this. You can see that if you're really, really lucky, you put this thing into the trachea. What are the chances of that happening? Really poor. Probably less than 10% of these actually go in the trachea. Otherwise, it's going to go down into the esophagus. And then you've got to be smart, too. You've got to know which one of these things should be, you know, to ventilate through. If you ventilate through the wrong one, and you're in the trachea, you ventilate the wrong one, you're going to fill up the stomach. So it's important that you know the difference, and we'll revisit those in the lab also. Here you can see the esophageal placement. It's got these little holes here, the air holes, and it just puts the air in there. Whereas if you're in the trachea, the air is going to come out that bottom tube. So if you've got this in the trachea and you're ventilating the esophageal one, then, is that right? No, if you've got, never mind. You can screw this thing up. I'm screwing myself up. Advantages of the combi tube, it's an alternative to you. If you can't get the oral intubation, then you have this as an opportunity or a choice for you. It's very quick, it's easy. This is almost a no-brainer unless you ventilate the wrong tube. Yeah, you can always ventilate your patient regardless of the placement. It does diminish gastric distension and regurgitation, they tell me. You can use this on a trauma patient because you don't have to hyperextend the neck. They're going to maintain that neutral position the whole time. And if you have got an esophagus, which most of the time is, you can place a NG tube in there, or actually an oral tube down there, and you can decompress the stomach, which is kind of handy. Can't be used if they're conscious. They have a gag reflex and suction. I already said that. Yeah, if you overinflate, let me back up here. If you overinflate this tube as well as the ET tube, this is when you're going to get damage to the airway. Cause ischemia. You know, most tubes are going to stay there for quite a while. It's not like you roll them in the ER and they extubate them. No, that doesn't happen. Now, they may pull a combi tube and intubate them, but particularly with the ET tubes, don't overinflate that balloon because you can damage them very easily. Okay, this is stuff you know. Didn't we just go over that? You can't use a combi tube on pediatric patients. Now, I think, did y'all look at the LMA, laryngeal mask airway? We're going to be looking at that also in the lab, maybe not next week, I'm not real sure, but some of the services around here are using the LMA. Y'all using the LMA, ETA?
We're getting rid of the combi tube and go to the LMA.
To the LMA, okay. Somebody, do what? Well, yeah, they're pulling the combi tube. They have a choice. You can use the LMA or you can use the King airway. I thought some of the services around here use the King. Anyway, we'll be looking at those in the lab. This is just some of the devices that are available. Y'all need to know all those. The LMA, if you haven't looked at the LMA, it's a very odd looking device. It kind of creeps me out. But you put this in, and this is the airway here, and this actually, you put it in facing up, and it seats right over the glottic opening. It holds that basically there. So when you ventilate that, you're only going to get the trachea. It's not in through the vocal cords, but it surrounds. Remember I told you there's that space between the base of the tongue and the glottic opening? You slide this in, and it kind of sits under it, and like this. And as you ventilate that, it'll ventilate very easily into the trachea, usually. Okay, I think I've already done this. McGill forceps, I mentioned this to you. You can use the McGills with just a plain sight where you can see it, or you can use a laryngoscope if you need to reach something that's a little bit deeper. But you know you got to be able to see it. You can't just poke around in there. Now we are going to talk about surgical airways in here. Yeah, we've got a few minutes. We're going to practice these in the lab too. Now this is new to Alabama. We've not been able to do surgical airways in the past, but it's going to be in those advanced protocols that are optional that you'll have to have been practicing for a while in order to be able to use. Anybody here from Georgia? Do they do, can you crike over in Georgia? Okay. I came out of Florida and we could do them down there. We don't do them here. Well, we will be doing them here, so that's kind of handy. The only indication for using to crike a patient or taking your scalpel to them is if you can't get an airway any other way. If you can tube them, if you can do a nasal, if you can do a digital, you want to do one of those before you go cutting in their throat. It is a fairly easy procedure, but there's always going to be risk involved, particularly depending on who's doing it. All right, you're going to have to know these landmarks. If you didn't know them for the test today, which I hope you did, you're going to, which you didn't, I guess. Was that on your test? I didn't see your test. Okay. Anyway, these are the landmarks. What is this right up here? Nobody knows. Hyoids here. This is the thyroid cartilage, the cricoid cartilage, basically here. This is the cricothyroid membrane. So there's no ring around there. No cartilage around there. It's just a membrane. This is where you're going to do your surgical airway. That's where we're going to do our surgical airway. Your book should have this drawn out. Does it have a picture of it somewhere in there? They don't? Okay. This one's pretty clear, isn't it? Okay, now, the first thing you're going to have to do, once you've made the decision that you're going to have to crike your patient, you've got to locate the landmarks. So you've got to palpate, and you can do this on yourself. You can feel those two little bumps. The top bump is what? The thyroid cartilage. The bottom bump is, y'all help me here, cricoid cartilage. That space in the middle is where you're going to stab. So you're going to have to palpate this so that you know where it is. You got to know where their thyroid is, where their cricoid is, and you're going to go in the middle. Once you've determined where it is, and that's what this guy is doing, once you've determined where the cricothyroid membrane is, you've got to secure it with your fingers. Just like I told you, once you see those vocal cords, your eyes stay there until you pass that tube. Same here. Once you've identified where that is, you're going to plant your fingers there on either side of it, hold it in place, keep it taut, and also so you don't have to look for it again. So here, hopefully you've got somebody holding the head. That's helpful. Now, there's several different devices that you can use to do a crike. Some are easier, some are harder, some you do more work, some are pretty much done for you. This one, as you can see, is not going to leave a really large airway. But here they're going to puncture from the top going down, right? We don't want to go from the bottom going up, right? We don't want to stab that through somebody's tongue. We want to go from the side because we want to stay in the trachea and not go all the way through to the esophagus. Good job. All right, so once you've punctured that, you're going to advance a catheter over the needle. It's kind of like you can do this with a really large gauge IV catheter. It's possible. You're like really in a pinch. Okay, here you can see you're kind of going at the angle. You're going to come, you don't put that in very deep. And once you've, later on we're going to actually cut this tissue and go in. It's really going to depend on what type of device your service is using. I have not used this one. We use the old cut it thing. All right, now this was a just a regular crike. Do they have a special name for it? No. Okay. This is where you're just going to use the little syringe and do it that way. The open crike is going to be where you use the scalpel and you make a cut. It's a little bit more challenging, but you really get a better airway doing it that way. You still got to locate the same landmarks because you're still going in the same place. You're going to have a little scalpel, and you're going to do a cut about 1 to 2 centimeters straight up and down this way, because most of your cut's going to be north-south. Then once you've got that, does it show there? And once you've got that, you're going to come back and make a horizontal cut. And once you've made that cut, you've got to put something down in there to maintain that. Either you're going to put your finger in there to hold that open, or a lot of the kits are going to come with some retractors that you can use. Now here you've got some hemostats, and they're using hemostats. They're putting it in there and they're spreading that laceration open. Now, hopefully, and there are 2 ways you can do this too. You can do your initial cut like this. You can clear out the tissue and then make your cut through the membrane, or you may actually cut the membrane at this time too. This particular slide part is showing you where they've already cut through the membrane. Now here you're going to insert a tube of some sort. I mentioned a Shiley to you earlier. A Shiley is going to be, just a little bitty part of your ET tube. It's going to be this part, and it'll have a little balloon, and it'll probably be about that long. You can use a big tube. My suggestion is you cut it off, but you're really going to do whatever your medical director, how he tells you he wants you to do it. And since this is coming in now, all the medical directors of the services are required to train you, not retrain you, but train you on whatever equipment you're going to be using. So make sure they do that. So you would just insert that just like you would an ET tube, oral ET tube. Once you've got it in, you're going to inflate the cuff, not overinflate it, but just inflate it enough to hold it in place there. and you can bag your patient that way. So you can see how short this little Shiley is. The balloon is just past the opening there. All right, you'll ventilate. You want to secure the tube in place, and you're going to auscultate, just like you do with all of your patients. What is the likelihood that you put this in the esophagus? Not very likely. You have to be really bad if you put this in the esophagus. You're probably going to bleed to death before you get anything else done. But this is not a real bloody procedure. You can get that cut really with a minimal amount of blood. And I've got some videos. I had it from last year. I'll have to find those now, where you can actually see these cracks being done. I had it in a review class. I'll find them and put them on the website. So you under modules, so you can see that. Okay, we already talked about this. These are just some of the cannulas that they'll use for a tracheostomy. This is a Shiley. That's what we were talking about if you have to do a surgical airway. These two go together. This is like the stylet here. Same thing here. So your patient may very likely already have one of these in place that he's breathing through. Or if it's somebody that's, say, hospitalized and they have one of these in place, you just bag over that. So when you do your respiratory rotations, have y'all done those yet? Okay. Make sure you ask a lot of questions and get them to show you anything that you may see in the field, because you don't want to come across something and go, what in the heck is that? So get them to show you everything. Be curious. And when you're suctioning, let's see. Be prepared to suction all airways to remove the, yeah, y'all know that, don't you? You know the different types of suction catheters, right? You know how to use them. If you've got a patient that is like vomiting big chunks of hot dogs and gross stuff like that, big chunks of steak that they haven't chewed well because they don't have any teeth, how are you going to suction that out of the airway?
With a shot bag.
Yeah, I've got one on the ambulance. Yeah, really, how are you going to suction that out? It's too big for the yonker. The yonker just has that little tip on there. I mean, this guy's eating a piece of steak that big. All right, you can pull the catheter off, but still my tubing is only this big. I got a hunk of steak this big.
Can you see it or can you not see it?
You can't see it. I just saw him eat it. How's that? Somebody told me. To suction it out.
Pull it out. Pull it off.
If you can't suction it out, you turn them on their side and you sweep it out this way. Okay. All right. What else? Gastric decompression. Has Brandy been over that yet? I think she's going to go over it. You know, you've got a couple of ways that you can do a gastric decompression. You can slide your little tube down the nose or through the mouth. So if they're conscious, how are you going to do it? Yeah, you're going to do an NG through the nose. Nasogastric technique. I think I've got some pictures of that. Let me back up. Yeah, if you've got a patient that the people before you, say, whoever was there before you, they were ventilating the patient and they filled the stomach with air. You've done your intubation, you know you're in, but they've got this big old fat stomach inflated with air. You have to get that out, right? Because why? What's the bad side effect of having a big old fat stomach filled with air? They may throw up on you. What else? If they throw up, they may aspirate.
It's going to be a big old burp when you're intubated.
Oh, that's so nasty. That's really bad. But really, think about it. You've got the stomach just filled with air. It's hard to ventilate them that way because it's taking up so much space in there. If you have trouble ventilating your patient, you can't get any air. And what else is a problem in the chest? The heart, yeah. If the heart can't expand and contract because of all the pressure in there, what's going to happen to your cardiac output? Yeah. So you're going to lose a lot of your cardiac output. That's one of the main reasons that they keep reducing, Jake, why they keep reducing how many times we ventilate. You know, when I first started, we ventilated once every 5 seconds, no matter what, and then we got after it. Now they've taken the emphasis off ventilation because one of the things we do is we overventilate. They got this big old fat stomach in there, and the heart's not working anymore. We can't get any blood pressure, no cardiac output. So what happens to your patient? They die. Yeah, so you've killed them. So anyway, sometimes you may have to do a gastric decompression. You're going to slip a tube down there and let all that air out and anything else. So you can do it through the nose or through the mouth. Through the nose for your breathing patients, your conscious patients. If they're totally unconscious, you can do it through the mouth. It's fairly easy because it's easy to get anything into the esophagus, right? Okay. Lots of times a patient will be brought to the ER because they've, taken some drugs. I'm going to kill myself. I've taken all these drugs. And they haven't killed them yet, so they're still sitting up, so they want to suck all that out of their stomach. That's one of the things that they do. Same type of procedure when we are decompressing the stomach. We're going to slide a tube down their nose and into their stomach. So the way we do that is you want your patient to sit forward and lean forward. You hope they're compliant. And you're going to lubricate that tube and gently, you might curl it too, it's going to make it a little bit easier. You're going to feed that down the nose. And you want to make sure you tell your patient, you have to swallow. When they're swallowing, what's going to happen? The epiglottis is going to close over the trachea. So that will eliminate the risk that you're going to put that in the trachea. You want it in the stomach. So you tell the patient, you just keep swallowing, you keep swallowing. And then after you pass the trachea, now they're going to help pass that while with their swallowing. So it's important that you have them swallow, have them sit forward, lubricate it, and have them swallow it. Now you want to make sure you measure it before you start to make sure it's long enough to hit the stomach. So what they usually do is you measure from the nose, around the ear, and then here to your cricoid cartilage. That's long enough to hit the stomach. So, all right. Now here it says, measure it here to the corner of the jaw or something. I don't care. I'm doing it to the cricoid. All right, if the patient is awake, suppress a gag reflex with a topical anesthetic. Yeah, I don't think we carry any sprays here, but some areas will carry a spray so you can anesthetize that, with some lidocaine or something. Okay, I already said that. Make them swallow. Now, once you've got that in place, you know that it's in the stomach, you want to secure it so it doesn't come loose. Now, you also should be able to apply some suction to that. If you're trying to, once you hit the stomach with that easy access, you may lose a lot of that air immediately. But if you need to evacuate anything else, you'll have to put a suction on there so you can suck that stuff out. Let's see. All right, changing topics here very quickly, and we're almost done. If you have to determine how much oxygen you have in your cylinder, you have a, what they call a C factor. If you just look at a tank and you open it up and you say, well, it's got 2,000 psi, does that tell you really how long a life you have in that tank? Not really. You can have a tank this big, and if it's full, what's its psi going to be? Per square inch? What's the pressure in there? At least 2,000. We consider 2,000 full. It'll be anywhere from 2,000 to 3,300, depending on how hot or cold it is outside. Whereas a little cylinder, say a D cylinder, what's the psi in there? Yeah, it's still the same. The pressure inside is going to be the same. It's the volume that's going to be different based on the volume or the size of the tank. So if you need to determine, say you're taking a patient, transferring from down here somewhere up to UAB, they're on a ventilator, say, you need to know how much oxygen you've got available to you. This is how you're going to do it. Your the tank pressure, your PSI, we hope it starts out at 2,000, times the C factor. And the C factor are these things. Say if I've got a M cylinder on the ambulance, I'm going to say times 1.56, and it's going to give me the number of minutes that should last. Anyway, nobody's going to memorize the C factors. Probably once in your whole life you might use this, and you're going to have to look it up. Oxygen delivery devices. Now y'all going, oh, we know those. Some of these things you're going to see, like a Venturi mask. There's going to be questions about the Venturi mask on National Registry. We don't use the Venturi mask in the field, but how is the Venturi mask different than, say, the non-rebreather?
You can dial this.
You can dial that. You can change the concentration of oxygen. It's a variable there. So patients that have long-term respiratory disease, they're in the hospital, they may adjust that, dial it down as the patient gets better. So Venturi mask, it's variable concentration. You can dial that up and back. A simple face mask, how's that different than a non-rebreather? Doesn't have a bag. So won't that suffocate the patient?
No.
No, because...
They're still, it's not sealed.
Yep, they got some holes in the side, so they're breathing ambient air there along with oxygen. You got it hooked up. So, anyway. Methods of ventilating. We don't do mouth to mouth, do we? The olden days we used to do mouth to nose on pediatric patients. Is that gross? Have you ever seen a kid that doesn't have a snotty nose? Anyway, mouth to mask. For those of you that had me before, you should remember this. Mouth to mask is the best way to ventilate a patient according to American Heart Association. So if you see that question on National Registry of the following, which is the best way to ventilate a patient, which of these will you select? Mouth to mask, because I told you, right. We don't carry masks for that purpose on the ambulances. You may carry one on your, in your person or in your car or something, if you had to do it when you're off duty. But mouth to mask is going to be the best way to ventilate a patient. Why?
Because you can feel when you get pressure, you're not over-ventilating.
Exactly.
You know.
Exactly. When you're blowing in there, number one, you can't blow more than you can exhale, which is going to be limited. I mean, if I've got both hands on that bag, I can put, 15 to 1,600 cc's in there. If I'm blowing in here, I'm probably not going to be able to blow more than 700 or 800. Who knows? I don't know how much. But you can feel the compliance in the patient. As you're filling their lungs with air, you feel that compliance. As it gets harder to blow, then their lungs are full. So from that standpoint, it's very handy. Back valve mask is going to be the way we're going to do it in the field if we have to ventilate a patient, right? Ventilating a patient and providing oxygen to a patient are two different things. What kind of patients do we ventilate? What's their respiratory status? They're either not breathing or they're breathing inadequate. Inadequate, remember what makes inadequate breathing? Those of you that had me before, you should know this. It's rate and volume. They're either not breathing fast enough or they're breathing too fast and the volume is insufficient. They're not getting chest rise. They're breathing too shallow. So if they're breathing inadequately, we're going to bag them. Or if they're not breathing at all, we're going to bag them. The demand valve device. Y'all remember that picture of that crazy thing?
The one with the really weird name.
Yeah, the frog book. Can't remember what it is. What does that stand for? F-R-O.
Like forced.
Forced.
We don't use it.
We don't use it. But what it does, it's got a demand, it's got a forced air ventilator on a pressure valve on here, and it's run by the pressure of the oxygen. When you push that button, it's going to go psh, like that. So you sit, what's it called?
It's the flow regulated oxygen powered ventilation device.
Flow what?
Regulated oxygen powered ventilation device.
Okay, did y'all get that? Yeah, me either. And there's not even a good acronym there. You can get a good seal on your patient with that. And when you depress that button, it's going to force air into their lungs. So what's the biggest problem with that? Yeah, it's very easy to overinflate. So they say you can control it, but you got to be good with your thumb or you're going to overinflate it. And then of course an automatic transport ventilator. Every ambulance should at least have access to a transport ventilator in case you had to transport somebody out of the area. BVM, built-in colorimetric. I told you guys that these are only good for one time with one patient, didn't I? Okay. Oh, this is the demand valve, which is the whatever. You can see the button on top. This is real handy because it doesn't require a whole bunch of people to do this. You usually can hold the mask in place with one hand and then run the demand valve with the other. Now this, because it says demand valve, Also, you could use one of these where when the patient sucks in, the valve opens and they're able to take oxygen, but we don't use those on the truck, so this is just one example of a portable ventilator. And what I tell you when we came in, being able to secure the patient's airway, be sure they have a patent airway, and then provide oxygen appropriately is the most important thing you can do. If your patient can't breathe, what happens to them? They die. I hate that when that happens. So next week, next Wednesday, what are we doing? Wednesday's cardiology, right? You're bringing two things. The small red book, your AHA, emergency care guidelines, and your workbook. Y'all hang on a second. I think he has a test.
I think we do have a test.
It better be short, because we've got a lot of ground to cover next week. Shh, y'all wait just a second. Take it down, take some deep cleansing breaths. Yeah. If you get the opportunity, go ahead and read about sinus rhythms and atrial rhythms, because we're going to cover those next week. Then you're going to have a whole bunch of practice strips to do. And if we've got to take a test first, that means we're going to be moving pretty quick through there. All right? Is today Thursday?
Yes.
Yeah, good. Y'all have a good weekend. Be safe. I don't want to read about you in the paper. I don't read the paper anyway, so somebody will probably call me and tell me.